Welcome to Journal Journey of 1st September, a joint activity of Raigad IIP and Maha IIP. Friends, today there is never-ending flow of information available 24/7 on net. It is quite difficult for a busy clinicians to segregate and pick up the exact latest ongoing research which he or she can use it for their patients. So ease out everything every month with guidance of our mentor, Dr. Nimen Mohanty sir. We are committed to provide best quality research papers. For today's episode, may I invite Raigad IIP member, Dr. Swati Hande to take over.
Good evening, ma'am. Good evening, everyone. Myself, Dr. Swati Hande, and on behalf of IIT Raigad, I welcome you all for a new edition of Journal Journey. I also welcome all the dignitaries, the chief guests, the guest of honor, presenters, experts, and all my colleagues for this session. Now, I would like to invite Maharashtra IIT President, Dr. Hemant Gangulia, sir, to share his thoughts and ideas. Over to you, sir.
Thank you, madam. Good evening and happy Ganesh festival to each one and everyone, the respected dignitaries on this Zoom dais, and to all the viewers, attendees on Maha IIP YouTube channel. Namaste, and on behalf of Maha IIP, Maharashtra Academy of Pediatrics, we welcome for today's episode of Journal Journey our chief guest, Dr. Abhay Shah, who is senior consultant and infectious diseases specialist from Ahmedabad. Guest of honor. So here is all the details of Dr. Abhay Shah. He is a senior consultant and infectious disease specialist, as well as today's guest of honor. Dr. Neha, can you make the full slideshow? So anyway, till the Dr. Neha madam shares, and our guest of honor, Dr. Chetan Trivedi, sir, President-elect 2022 of Academy of Pediatrics, Gujarat, and is very popular as a scientific convener of Wednesday Wisdom. He's always spreading the pulse of science across the country, and almost they have celebrated 1 year of the episodes, and they have entered another year. We welcome experts. So here is Dr. Chetan Trivedi, sir, National Trainer, many CIP modules, President-elect AOP Gujarat 2022, as well as today's experts, Dr. Charul Mehta, madam, Associate Professor from BJ Medical College and Civil Hospital, Ahmedabad, Dr. Sandhya Khadse, madam, Dean of DM Medical College, Wanadongri, Nagpur. The presenters, Dr. Divya, Dr. Ashana, madam, today's moderators, Dr. Chitra Kulkarni from Navi Mumbai, Raigad, and Dr. Swati Hande from Panvel, IIP Raigad office bearers, Dr. Wankhede sir, our President, Secretary, Dr. Dhananjay in absentia, our state convener, Dr. Jay Bhandarkar, as well as my secretary, Dr. Amol Pawar in absentia, office bearers of Maha IIP, EBs, and office bearers of IIP Raigad. And the most important pillar of this journal journey, or our mentor, Dr. Nimen Mohanty sir, and all others, as well as I can see Dr. Sunita Ingle madam also, Dr. Charul Mehta, and everyone. Well, as WhatsApp message of Journal Journey, which is drafted by Dr. Neha Singh, says, learning is a journey that never ends, and the destination expands as you travel. And I distinctly remember the journal on the Doctor's Day, 1st July 2021, when first Journal Journey episode was started. Myself, Dr. Jay Bhandarkar, under the guidance of Dr. Mohanty sir, and then IIP Raigad President Dr. Sunita Ingle and Secretary Dr. Nilima Bhandarkar. The first journal episode was started on 1st of July 2021. Then this year, it was just that was across the district of Raigad. Then it went to the state. So Maha IIP, I thank Dr. Wankhede sir to help us to get associated with Journal Journey to spread across the Maharashtra state. And today is the happiest day I feel so for each one of us. It is going across in the West Zone. So today we are seeing all Gujarat presenters, Gujarat experts. So, and hope so in the next episode, we will see to the Goa, and probably on the third episode of November, we may see the across the country inviting Telangana state also. So this is today is the most happiest day, I think so. So let us see how it works. And thanks a lot, Dr. Abhay Shah, Dr. Chetan Trivedi, as well as Dr. Charul Mehta, who made these things to happen for today, all having to get all together, things together to have this episode. So wish each one and happy learning and a fantastic journal journey episodes. Thank you, madam.
Thank you, sir, for your kind words. I now request Raigad IIT President, Dr. Pramod Wankhede, sir, to welcome our esteemed and respected guest to today's session. Over to you, sir.
Before Dr. Wankhede, sir, we also thank IIP Palghar President Dr. Anjali Madam, who has also joined this episode. Thank you, madam.
Thank you.
Thank you very much.
Thank
Good
you.
evening to all. Today's chief guest, Dr. Abhay Shah, sir, guest of honor, Dr. Chetan Trivedi, sir. Today's expert, Dr. Charul Mehta, madam. And another expert, Dr. Sandhya Khadse, ma'am. Our mentor, Dr. Mohanty, sir, under whose guidance this journey is going on. And our dynamic president, Dr. Gangulia, sir. Dynamic secretary, Dr. Amol Pawar. Convener, Dr. Jay Bhandarkar. Today's moderator, Kulkarni, madam. And Hande, madam. And Dr. Neha, the main source of communication for this program. So good evening to all and happy Ganesh Chaturthi to all. As you know, this journey is ever going on, and we are exploring new topics of interest and new horizons of academics. With this program, we get opportunity to hear the experts like Dr. Abhay Shah sir, Dr. Chetan Trivedi sir, and experts like Sandhya Khadse madam and Charul Mehta. So this is a boost for us to increase, to update our knowledge, to get more information, to get wisdom from these experts. This is a brilliant program we are conducting. I wish this program should be never-ending program, and I congratulate both the speakers that they took initiative in this program. I congratulate them and thank you very much, and I wish best success for this program. Thank you.
Thank you, sir, for the warm welcome amidst the festive fervor of Ganesh Chaturthi. I now request our chief guest for today's session, Dr. Abhay Shah, sir, to give us his blessings on the occasion of Journal Journey.
Yeah.
Over to
So, good evening. Can you hear me properly?
you. Yes, sir.
Yes, sir.
Yes, sir.
Yeah. So, good evening, everybody. And I wish very happy Ganesh Chaturthi. May Lord Ganesha bless you with a lot of happiness, health, and prosperity in the years to come. President of Maha-IP, my close friend, Dr. Hemant Gangulia, coordinator, Dr. Jay Bhandarkar, secretary, Dr. Amol Pawar, I think he has not joined. And of course, the local Raigad branch president, Dr. Pramod, Dr. Vikas, and Dr. Dhananjay, the treasurer and the secretary respectively. And the backbone of this journey, that is Dr. Mohanty sir. I think he's a teacher of the teacher. So I speak his name with due respect and due regards. My namaskar sir to you. And also to experts, that is Dr. Sandhya Khadse and Dr. Charul from our own Vijay Medical College of Ahmedabad city. It's a proud happening today because both the presenters are from Ahmedabad, and it has been aptly supported and guided by Dr. Charul. So, and also all the experts and the Dr. Chetan Trivedi, my colleague from Ahmedabad, who is also on the dais, I would say on the e-dais rather, with me. So, as rightly mentioned by Dr. Neha, that this is the learning is a journey, which is an endless journey. And as we rightly mentioned, by that illiterate of the 21st century is one who does not learn, unlearn, and relearn. So I totally endorse the views of Dr. Neha and Raigarh branch and MyIP branch that yes, learning is to be there and it's actually continues. And the most important part of this journal journey is that we used to have our journal club. When we were students, we were used to have a journal club. And most of the time, the students, the postgraduates, and even the teachers would err on the side of escaping this event by putting one or the other reason. So I congratulate Raigarh when first to take this initiative well back in 21 July. And again, putting it to a larger horizon to percolate this knowledge to across the West Zone, that is MyIP under able leadership of Dr. Gangolia, Jai, and Amal Pawar. So congratulations to the team. Now, as you know that this journal club or journal journey is mainly to review the literature and to critically analyze the findings. And thereby, we need to create an evidence-based medicine which can be or should be reflected in our day-to-day practice. That is the purpose of it. And if you look at the history, William Osler started this journal club at a baker's shop. And at that time, the purpose was to distribute and to read the periodicals who were not having money to subscribe that particular periodicals. And we have got our Harrison, Principles of Medicine, that is written by Harrison. Harrison used to call his friends twice a month for this journal journey. So it is a very deep roots, but somehow this root has not flourished. And therefore, instead of having a tree, a dense tree, I think we are at the vanishing end of it. And the pipeline is so dim that probably today in 2022, we see hardly of this activity. So I think it's a big, huge accolades to the Maharashtra IAP, to the Raigarh branch, and on ODIAP and CIAP for taking this. So now we have the postgraduates who are very busy. Always they are under tremendous pressure of the work. But in spite of this, taking this, they have taken this initiative. So congratulate to both the presenter, to their guide, and to the mentors as well. And I hope that this will continue for a long time. With one more important suggestion that let it percolate to our own physician who are practicing. So because this research methodology is a forgotten art, and I'm sure that this will give a big stimulus to all who are there on the dais. So thank you, friends. Thank you for inviting me, giving me this honor. I think IIP Raigarh is my second home. I'm coming repeatedly, either physically or virtually, because of friends like Dr. Pramod and Dr. Hemant and Jai. So thank you so much. And once again, my namaskar to Dr. Mohanty sir and all the viewers. Thank you so much for giving this wonderful opportunity. I will miss the science because of some commitment after 30 minutes, but I will still there for next 30 minutes and then I will leave. Thank you so much for this opportunity. Thank you so much.
Yes, sir. We know your busy schedule, and thanks for sparing your valuable time for us for today's episode. Thank you very much.
Thank you, sir, for your blessings and kind words of inspiration. I now would like to request our guest of honor, Dr. Chetan Trivedi, sir, to share his thoughts about journal journey. Over to you, sir.
Thank you. Good evening to all. First of all, happy festive season, Ganesh. The processions must be going on since 2 days, and now we are into the, so much for Lord Ganesha. We wish that Lord Ganesha will bless all of us for a wonderful future ahead. At the outset, first, I would like to, thank Dr. Hemant Gangolia, Dr. Jai, and Dr. Amol and team Maharashtra for this wonderful opportunity. I also thank IIP Raigarh team led by Dr. Pramod, Dr. Vikas, and Dr. Dhananjay. And I pay my respect and regards to Mohanty sir. He has been instrumental for this sort of activity. And I acknowledge the presence of our own Dr. Charul Mehta. She's from our own city, and she belongs to the institute. She's working in the institute where I used to do my PGs. So it really takes me back to those days where as Dr. Abhay Shah told, it's a journal club. And so the habit of looking at the journal should come right from those days. And those were the days when we were PGs. There were no compulsion for presenting papers or doing some research activities. So as Dr. Abhay said, we used to, find the excuse to, escape these things. But we know that our brain knows only what our eye sees, and what our brain will know, what we have read. So this particular thing, the journal journey, it's an amazing journey, what I witnessed like since so many years. And we have able leaders like Dr. Hemant Gangulia sir, because he is known for his innovations in many things. So he has picked up this particular journal journey and continued and made it to a mega scale. And now he has gone beyond the Maharashtra and he's entering into the Gujarat and then Goa. I wish that this program should percolate more and more. See, nowadays what happens, journal, when we talk about our residents, PGs, like that. But it is really a necessity for all practicing pediatricians also. Because what happens when we as an academicians, or when we are taking a part as an academician to some event, we have to refer this sort of references. So if you don't have the habit of referring it, then it is very difficult to find these references. So once you have started developing the habit of going through this journals, I think it is good thing in the future of all of us. And I usually have habit of, whenever we get some journal, reputed journal. So usually in the practice, we don't get time to go through at a stretch. But at least what we do, we see at the index. And then out of that, at least 1, 2, or 3, you can pick it up that you think that this can be helpful to me in my practice. So I just tick mark it and put the note over it. So whenever I get time, I read that. That's the way I think practicing pediatrician should be looking at the journals, because journals will be having so many things. But now what best you need, you have to decide and take it up. So I think journal journey is an amazing thing, very innovative things. I think we should go ahead and more and more people should join this journey. And thank you all for this wonderful opportunity, because this is, guest of honor is a big honor for me to be a guest on such a wonderful platform, on a wonderful this series of journal journey. I am very happy to be part of you in this journey. Thank you once again. And I would definitely acknowledge the presence of Dr. Chitra ma'am, Dr. Neha, Dr. Swati, and if I miss Dr. Divya, I am particularly Ashna. Those two are going to present, and Dr. Sandhya Khadse ma'am and Dr. Charul. I wish you all the very best of happy learning. I'll be part of it. In between, I might have to skip, but yeah, definitely I will be enjoying the session. Thank you so much for the wonderful opportunity.
Thank you, sir, for your kind words of motivation and guidance. Now I would like to request Dr. Jay Bhandarkar, sir, Maha IAP State Convener, to introduce our dear Dr. Charul Mehta, madam, expert for the first topic for today's session, and the presenter for today's session, Dr. Divya Prajapati. Over to you, Jay.
We acknowledge the presence of Dr. Rajesh Boog, also Vice President of MAHAIP, as well as Dr. Renu Boralkar, Chairman of the MAHAIP Women Committee. Yes, Dr. Jay.
Yeah, thank you, Dr. Swati. And good evening and happy Ganesh festival to all of you and all seniors on the dais, off the dais, and on the YouTube. Friends, we started it as Dr. Hemant already said, and I was in the habit of attending all the journal clubs during my own PG days and continuing even after started practice at the Solapur Medical College. So thank you for joining. And I know knowledge doesn't have that boundaries, right? It must go all over globe, I can say. So we are now entered in the phase of joining to the Gujarat, and hope so we'll going on CIP level also. So I like to introduce Dr. Charul Mehta. She is assistant professor at BJ Medical College, Civil Hospital, Ahmedabad. And thank you for this. She was an instructor for the BNCRP Advanced NRP, as well as certified DACIL assessor and NIBH and Kayakalpa assessor, as well as co-investigator for ICMR project on National Rotavirus Surveillance Network, and a resource person for the health program, many health programs. and trained as a trainer for many IP programs on nutrition, adolescent, and clearing pediatric airways and growth monitoring chart. So thank you, Dr. Swati. I can say we can go further, start journey of today's. Thank you. And I think we have I have to
Dr. Jai,
introduce
you have to introduce the
first
first
presenter
presenter
also.
also.
So our first presenter is Dr. Divya Prajapati, and she's at present PG at the Vijay Medical College Civil Hospital, Ahmedabad, and she's going to present today's first our article. Welcome, Dr. Divya Prajapati also. Thank you.
Dr. Divya, you may start.
Okay.
Dr. Divya,
Good evening.
please share.
Yes, ma'am. Yes. Am I audible?
Yeah.
Hello. Miss, shall I start?
Please. Yes, please.
Good evening, everyone. Today evening, I am very grateful for academic reading of journal journey in Maha IIP and IIP Raigad on topic of STARS neonatal AKI risk stratification cutoff scores for a severe AKI and need for dialysis in the neonates. What is STARS? STARS, this score model named after the author's name, that is S from the Sethi, that is Siddharth Kumar Sethi, T from the Tibrewal, that is Abhishek Tibrewal, A for the Gopal Agrawal, that is Gopal Agrawal, sorry, T for Tibrewal, that is Abhishek Tibrewal, A from the Gopal Agrawal, and R from the Rupesh Raina, and Z from the Sanjay Wazir. This article is published by the Elsevier in the International Society of Nephrology in Kidney International Reports.org. Neonatal acute kidney injury is a significant pathology associated with higher mortality rates, longer neonatal intensive care stay, and worse clinical outcomes. In order to mitigate the avoidable outcomes, it is important to identify AKI early and start early therapeutic measures. Previous attempts to derive illness severity scores, that is the clinical risk index for the babies, simplified age, weight, sex scores, pediatric risk of mortality, and pediatric index of mortality among neonates and children. Those illness severity scores only assess the illness severity and cannot be used for the risk stratification for the AKI or mortality. Stratifying the neonates into an at-risk category allows the healthcare providers to objectively recognize opportunities for improvement in quality of care. That is, the research letters of interest reports cutoff score required for identifying risk of severe AKI and dialysis need in neonates, which would be very helpful in day-to-day neonatal practice. Impact. The STARS neonatal scores serves to rapidly and quantitatively determine the risk of AKI in neonates admitted to the neonatal intensive care unit. These neonates with a higher risk stratification score need intense monitoring and daily kidney function assessment. With this intensification of research in the field of AKI risk stratification prediction, there is hope that we will be able to decrease the morbidity and mortality associated with AKI in this population. Now, materials and methods. This study design, the Tinker study is a multicentric national and prospective cohort study is used. Tinker work group is helping in this study, that is the Indian PCRRT Iconic Neonatal Kidney Education Registry study. A multivariable logistic regression technique with stepwise backward elimination method was used and a risk prediction scoring was devised, that is the STARS score. Study location, neonatal intensive care unit from all the collaborative 11 centers across the India. And duration is 2 years from the September 2019 to August 2021. Inclusion criteria, all admitted neonates who need the intravenous fluids for at least 48 hours And exclusion criteria, mortality within 48 hours of admission, neonates not on any intravenous access, lethal anomaly including trisomy 13, 18, and anencephaly, neonates who needed congenital cardiac surgery within the first week of life, since these neonates are referred. This model includes the 10 variables with a total score ranging from 0 to 100 and a cutoff score of 31.5. From the history, the neonates age at entry in the NICU either less than 25.5 hours or more than or equal to 25.5 hours. Positive pressure ventilation in the delivery room given or not. Gestational age less than 28 weeks or more than or equal to 28 weeks. During the NICU stage, whether baby have sepsis or not, significant cardiac disease, that is hemodynamically significant patent ductus arteriosus, persistent pulmonary hypertension of the newborn, cardiogenic shock, and other congenital heart disease. Urine output less than 1.3 ml per kg per hour. Serum create more than or equal to 0.98 milligram per deciliter. Use of nephrotoxic drugs, that is vancomycin, colistin, and amphotericin B. Here the drawback is these authors did not include the other nephrotoxic drugs like the aminoglycosides, which we usually routinely used. Sixth one is use of furosemide, and seventh one is use of inotropes like dobutamine, dopamine, epinephrine, and norepinephrine. Here, another variable, that is some congenital anomaly like posterior urethral valve, PUJ obstruction. That congenital anomaly is also not included in the inclusion criteria in the variables. This is the STARS coding model, and they have assigned the 10 variables for which they have assigned the different scores according to their studies. And a value of more than or equal to 31.5 indicates greater probability of AKI incidence within the 7 days post NICU admission. In this study, authors have included 1,855 patients, among which 790 patients are excluded who have receiving routine care in the nursery without IV fluids for less than 48 hours, and deaths within 48 hours of admission. And among them, they enrolled the 1,065 patients, and again they excluded the 60 patients who have any lethal chromosomal anomaly and congenital heart surgery within the first 7 days of life. And finally, they included the 1,005 patients for a final analysis. Among them, 359 patients developed the acute kidney injury, and 646 patients having no acute kidney injury. The neonates with admission in the NICU within less than 25.5 hours of birth, requirement of positive pressure ventilation in the delivery room, less than 28 weeks of gestational age, sepsis, significant cardiac disease, urine output less than 1.3 ml per kg per hour, or serum create more than or equal to 0.98 milligram per deciliter during the first 12 hours post-admission, use of nephrotoxic drugs, use of furosemide, or use of inotropes had a significantly higher risk of AKI at 7 days post-admission in the multivariate logistic regression model. So in the validation cohort, this scoring model was observed to have a sensitivity of 92.8%, specificity of 87.4%, positive predictive value of 80.5%, and negative predictive value of 95.6%, and accuracy of 89.4%. And based on the STARS cutoff scores of more than or equal to 31.5, an area under the receiver operating characteristic, that is ROC curve, was observed to be 0.932, confidence interval 95%, and p-value less than 0.01. That is signifying that the discriminating power was very high. This is the comparison between the different variables among the neonates without AKI versus stage 1 AKI versus stage 2 AKI and versus stage 3 AKI. And the authors found that stage 58 patients developed the stage 1 AKI, 77 patients developed the stage 2 AKI, and 224 patients developed the stage 3 AKI. And median STARS score was 34, length of NICU stay was 10 days. This is the and the comparison of different variables among the neonates with severe AKI versus mild to moderate, that is stage 1 and stage 2, is presented to p-value of less than 0.001 in proportion with significant cardiac disease, inotropes uses, serum create more than or equal to 0.98 milligram per deciliter were significantly higher among those with the severe AKI, and STAR scores was found significantly higher with severe AKI. This is the comparison of different variables among stage 3 AKI neonates with versus without peritoneal dialysis. And median STAR scores was significantly higher among the stage 3 AKI neonates who treated with the peritoneal dialysis than the patient without peritoneal dialysis need. To summarize, the author found the following cutoffs for the neonatal AKI prediction. STAR scores less than 31.5 predicts low probability of AKI. STAR score less than 59 predicts low probability of severe AKI. STAR scores less than 66 predicts low probability of severe AKI with the need for peritoneal dialysis. The cutoff scores were found to increase with the increased AKI severity. Conclusion: this is the first of its kind national study to use a scoring system that can easily be replicated in the NICU as per authors. The cutoffs mentioned in the study can help a clinician to determine the need for the dialysis requirement, to anticipate severe neonatal AKI, and an easy and beneficial clinical adjunct to neonatal intensive care units of all types. Nevertheless, further studies are needed to validate the cutoff scores. Thank you.
Now Charul madam to take over for the expert comments.
Yes, ma'am. Good evening, everyone. Am I audible?
Yes, ma'am.
Yes, ma'am.
Ma'am, I'm audible?
Yes.
Yes, yes.
Okay. So at the outset, I would like to thank the and office bearers of Maha IAP and IAP Raigad for giving me this opportunity to mentor my students. I'm proud to say both are my PG thesis work for this presentation. And as Dr. Abhay sir and Dr. Chetan Trivedi, as well as our other respected dignitaries have already told that we, during our PG time, we were doing this journal reading, and initially when this offer came to me, that would really
Madam, your voice is cracking and a little bit. So,
be able to give time, because at Vignaharta, Lord has come us to come.
hello, madam, can you put off your video and just
I
keep
will do one
audio
thing.
on?
I will stop my video because
Yes.
yes,
It's
sir.
now
Yes,
it's
sir. I'll
fine.
stop my video.
Yes. Go ahead.
So there were a lot of hurdles in between. I was a bit skeptical, but Vignaharta Lord has arrived, and today this has made it successful, and I'm very proud to say that I'm part of first West Zone Journal Journey Club. Okay, without wasting time, I will go ahead with my observation. Uh, on doing a critical appraisal, I could highlight few things. I would tell positive things first, that this is a Herculean task to carry out such a study across the nation involving 11 centers, multicentric study. So it is a appreciable move by the authors who have collected all the data. And as I can found by doing a detailed analysis, that there were several phases of the study. As mentioned somewhere in the supplementary material, that original STARS study or score was different, which was actually done in August 2018 to 2019. And this is a refined one, which was then carried out in September 19 till August 21. They have defined significant cutoffs for all the variables as described by Dr. Divya. And ultimately, their conclusion is also good, that we can use this score to stratify the risk of kidney injury in neonates which is many a times due to busy day in, day out neonatal schedules, we are overlooking or probably we are not monitoring those minute changes. So it is really a commendable job and task done by the authors. However, I could not find a few things. As Dr. Divya has rightly pointed out that aminoglycoside was not mentioned, but there was a discrepancy in two tables in supplementary material. Supplementary table 1 did mention that there was no did not mention that there was aminoglycoside, but in supplementary table 2, they have found out, they have written in the footnote of the table that aminoglycoside was included. So, what is the truth? Actually, we need to find out from the authors. Another thing which makes me doubtful about these utilities, there are multiple variables, and scoring them and collecting data for each variable would be really a cumbersome task, and we would require a dedicated religious data entry operator who would enter all this data, because probably when they were doing study, there will be investigators assigned for that and they must be doing it religiously. But to extrapolate all these activity across all the SNCUs throughout our nation, I have my own doubts. Another thing is, I really want to find out that how did the authors have put this cutoff of 25.5 hours? Like whenever we assign thesis, sometimes we put exclusion criteria of 24 hours or 48 hours, keeping something in mind like early neonatal period, the complications are higher. But why they have put this cutoff of 25.5 hours, that I am also scratching my head. I could not find an answer for that. So these are my observations. Probably other experts, Dr. Sandhya ma'am and Dr. Hemant Gangulia sir, may tell their expert opinion regarding this. Thank you.
Thank you, Charul ma'am.
Thank you. Thank you, Ms. Charu ma'am.
Dr. Mohanty sir,
we-
anything you have to say about it? And Dr. Sandhya madam.
Actually, the methodology have to be discussed in little more detailed. It's lack of time, she could not do it. The morbidity and the inclusion criteria says babies who are on IV fluids for 48 hours, and the exclusion criteria, they have said those who are not on IV fluids. If you're in inclusion criteria, you have included some people in the basket, you don't have them to exclude them. So this is a lapse. And they have not clearly mentioned about the pilot study, which probably the study which they conducted earlier, it could have been a pilot study. And the result of pilot study, where it has been validated, should be mentioned. Unless it is validated, you cannot use in a regular study. It's an ethical issue also. So these things have to be taken into account. Under the circumstances, we just cannot recommend this to be used across the country unless it is really validated by a professional body. It's very, very important. And validation prior to the study has to be validated by professional bodies. It's authenticated. Will not spend much of time. Ma'am, you have got any asset budget for them? Sandhya ma'am.
Dr. Sandhya ma'am.
You're not audible, ma'am. Unmute, ma'am. Yeah.
Yeah. I fully agree with Mohanty sir. These two facts came to my attention also, that this study has to be a piloted study as such. Validation is not there. And overall, like recommendation, what you have very rightly said, we cannot recommend it to the entire group as such or the country level because of this particular cap, or I should say the limitation which this particular study has. However, the design and other aspect of the study, that is quite good. I think if they go in recruitment of more cases and then come out with some sort of a validation, probably then we can go ahead with few recommendations.
Yes, correct.
Thank
Dr.
you, sir.
Moite sir
Thank
want
you,
to
ma'am.
add something if he is there, if he has heard that article. Dr. Moite sir, yeah, if you are there.
Please request Dr. Bishal. Please, Dr. Bishal to attend, please. He's not getting full screen. It was in the practice sessions also, it was like this. So please make it full screen.
Okay,
And,
sir. For next article, we will make full screen. Now go ahead, Dr. Sandhya.
Thank you.
Sir, at our end, it was full screen. We are able to see the full screen.
Yes, I could also see.
Yes. Yes, go ahead.
Thank you, Charu ma'am, Sandhya ma'am, Monty sir. Now I would like to request our second moderator, Dr. Chitra ma'am, to introduce our expert for today's session, Dr. Sandhya Khadse madam, for the second topic, and the presenter for today's session, Dr. Ashna. Over to you, ma'am.
Yeah, good evening, everyone. And
Dr. Divya, will you
yes,
stop your sharing screen?
yes. Yeah, Mohite sir is there. Okay, after this topic, we will ask her to give his comments. Dr. Sandhya Khadse madam's introduction I am going to do now. Dr. Sandhya Khadse is an achiever. 6 gold medals from Miraj Medical College and IGMC Nagpur. She is Chief Child Health Monitoring Officer for Government of Maharashtra with affiliations in Singapore and USA. She has 40 awards till date and still new feathers added in her cap. Recently, she has started first human milk bank in Nagpur area in Datta Meghe, where she is academic dean. Her immense contribution to pediatric fraternity in form of 6 textbooks, 175 publications in journals, both national and international, 235 guest lectures so far, and has agreed to be our expert today for Journal Journey. Thank you, Sandhya ma'am. And our topic of discussion is very near to her heart. She has worked for tribal children in Melghat for 1 year and made a lasting impact by creating a SNCU in that area. The presenter for second topic is Dr. Ashna Verma. She is a senior resident from Gujarat Civil and under the guidance of Dr. Charul ma'am, third year resident. Dr. Ashna, you can start.
Thank you, Chitra, for the introduction. Good evening, everyone. I'm Dr. Ashna Verma, resident doctor from BC Medical College. Today, I'm here as a presenter for this academic reading of Journal Journey.
Ashna, your voice is not clear. Your voice is not clear.
Yes. Is it still not clear, ma'am? Am I audible?
Yeah.
You are audible, but little bit
Your
muffled.
audible screen is not clear. Yeah.
I will be sharing screen shortly.
Yes. Yeah, now I think it's clear.
Okay. So is the screen visible?
Yeah.
Hello?
Yes. Now it is visible.
And And am I audible now, ma'am?
Yes, you are audible.
Okay. Okay. So, good evening, everyone. And today I'm here to present this article from the very prestigious journal of Indian Journal of Public Health with an impact factor of 2.19. And the topic of my article is impact of intervention on nutritional status of under 5 in tribal blocks of Palghar district in Maharashtra. And I'm presenting this under guidance of Dr. Sandhya Khatse ma'am. So, undernutrition amongst children is a major public health problem, and it jeopardizes children's survival, health, growth, and development, and it slows nations progress towards development goals. There is a need to improve their nutritional status of under 5 children through specific targeted interventions. The present study is a part of multi-center study conducted by ICMR to improve nutritional status of vulnerable segment of population. And ICMR did this for adolescents, for pregnant women, and also for under 5 children. Why this study? In India, under 5 children contribute to the most vulnerable segment, and the prevalence of undernutrition is nearly double that of sub-Saharan Africa. Tribal populations are particularly vulnerable to undernutrition because of their geographical isolation, socio-economic disadvantage, and inadequate health facilities. So here, this article emphasizes on this interventions being done on tribal population, shows how much impact it has on their nutrition and improvement in the health status. Study type is that of a prospective pre and post intervention study, and the location was 10 villages of 2 tribal blocks of Palghar district in Maharashtra, India. Duration: pre-intervention survey was conducted from July 2015 to August 2016, and intervention was implemented for 18 months, that was from September 2016 to February 2018. The study participants were under 5 children in these 2 blocks, and a total of 480 children were recruited during study period after obtaining birth parents. Under the district, 2 blocks were selected random, and from each block, 5 villages were selected by the probability proportion precise sampling method. Interventions were implemented via household visits, sending mobile short messages in local language, and mass approach. These household visits were carried in 3 rounds and were completed in selected villages in each house of the village under 5 children. Mobile messages were sent to the beneficiaries in their own local language. Mass approach mainly covered discussion of the importance of iron-rich food in diet, iron folic acid consumption, advantages of exclusive breastfeeding lectures on IYCF practices, initiation of weaning, and types of complementary feeds through role play. Discussion meetings were conducted about the usage of take-home ration by mothers of under 5, and special nutrition sessions were conducted to demonstrate low-cost nutritional recipes to ASHA workers, Anganwadi workers, and mothers of under 5 children. The impact of intervention was assessed by comparing important indicators in the pre and the post-intervention survey. To understand difference in the outcome of pre and post-intervention, the Pearson's chart and Fisher's exact test was performed. A two-sided P less than 0.05 was considered statistically significant. And the hypothesis of this article was nutrition intervention into health status of children. The results included that the breastfeeding rate improved from 48.9% to 50.5%, and initiation of complementary feeding at 6 months improved from 48.3% to 72.5% in the post-intervention survey as compared to pre-intervention survey. Although considering the exclusive breastfeeding rates, they did not mention as to when was the breastfeeding initiation. And Also, the minimal meal frequency increased significantly from 67.03% from 5.91%, and minimal acceptable diet improved from 5.37% to 47.2% in the post-intervention survey. Interestingly, the prevalence of severe acute malnutrition SAM reduced from 5.4% to nil, whereas severe stunting and underweight significantly decreased by 17 and 8% respectively in the post-intervention survey. Although it is little dicey as to how did the stunting improve in the short span of 18 months, but their results showed improvement. Severe anemia decreased from 16.24% to nil in the post-intervention survey. Now, this slide shows the rate of exclusive breastfeeding, which improved from 48.9 to 50.5, as mentioned earlier. And the introduction of complementary feeds also improved significantly. And there was the minimal meal frequency had changed from 5.9% to 67%. And of that of minimal dietary diversity increased, changed from 67 to 58%, and minimal acceptable diet changed from 5.37 to 47% in the post-intervention survey. This result table shows that the children falling under the normal weight band increased from 72.9% to 90%, whereas those falling under MAM and SAM had reduced significantly. That of MAM had reduced by 50%, that is 20% reduced. SAM reduced from 5.4 to 0%. Underweight also reduced. Severe underweight reduced from 32 to 23%, and moderate underweight reduced from 15 to 13%. Stunting, there is a change seen in severe stunting, that is from 42% to 25%, but moderate stunting more or less remains same. Assessment of anemia. So hemoglobin had hemoglobin levels, mean hemoglobin level improved from 9% to 19%, and severe anemia reduced from 76% to 0. And this shifting was actually seen in the moderate anemia levels. So the level of severe anemia reduced, but that of moderate anemia reduced, probably due to those falling under severe improved to moderate anemia. So here we conclude that the present study highlights impact of health and nutrition education, emphasizing consumption of local nutritious food by means of household visits and mass approach. At PSC level, improvement of nutritional status of under 5 children through the involvement of community health workers seems to play an important role. And community health workers, along with the mothers in the neighborhood, when they prepared food, nutritious food of those ingredients were available locally, made a huge difference, and holds a important role in, compliance and how they follow the same trend in future too. Further, better design and implementation of nutrition interventions at programmatic level to reduce child mortality and morbidity in globally. There were few limitations of this research, that the post-intervention survey could not cover 100% of the beneficiaries of intervention of those included in the pre-intervention survey. However, they could include almost 70% of the beneficiaries from the pre-intervention survey, and the shortcoming was majorly due to migration, social issues, and those children who after 18 months fell above 5 years of age. So they were removed from the eligibility criteria. And despite approaching all eligible children in the post-intervention phase, the number of infants and young children less than 24 months were proportionately less in the post-intervention and not uniform in pre and the post-intervention phase. Financial support and sponsorship for the research was Indian Council of Medical Research, and there were no conflicts of interest. Thank you.
Yeah. Thank you, Dr. Ashna. But we were regretfully have to declare that the voice was muffled, probably because of the net connection. But the slides were very good. Over to Sandhya ma'am.
Yeah. Thank you, Ashna.
Thank you, ma'am.
Sandhya ma'am, please unmute.
Yeah, am I audible? Hello.
Yes. Yeah.
Sandhya ma'am, please unmute yourself.
Hello.
Yes, ma'am.
Madam, unmute, please.
Madam, you are getting unmuted and muted. We remove after getting unmuted. Please remove the cursor from there.
Okay.
Yes, done. Go
Yeah.
ahead.
So my compliments to Ashna for wonderfully presenting and summarizing the very elaborate paper so nicely. First of all, coming to the comments on the paper, it's an ICMR sponsored study and done by the ICMR people. So definitely validation and all design part of the study, everything is very meticulously taken care of. The results are also very encouraging, that if a proper educative intervention is done in the tribal area and in the tribal community, definitely we can improve the complementary feeding rates, and we can go ahead with reducing the malnutrition as well as the infant and neonatal morbidity and mortality. But regarding some of the issues which really is coming to my mind is that the study very well quotes that early initiation of the breastfeeding was very good, more than 78.2, even in the pre-intervention group. And in the post-intervention, it almost increased to more than 90%. So if the early initiation has been started by the mother, then why there is problem in exclusive breastfeeding? This is a big question mark which has come from this study, that the exclusive breastfeeding rates in the group, that is not increasing to more than 2%. 48% was in the pre-intervention and some 50 point something is in the post-intervention. So we take it for granted that if the mother is doing the early initiation of the breastfeeding, then definitely the exclusive breastfeeding rates will be good. And then the mother doesn't require much more education regarding breastfeeding. This is what we consider. And once the early initiation has been done, we just leave the mother like that only because we take it for granted that she will continue the exclusive breastfeeding. But this study has really highlighted one very important aspect, that it's just not the early initiation of the breastfeeding, but for exclusive breastfeeding, further education and further intervention is also required. That is something which is which we have to think about by this particular study. One more thing is that I worked in Melghat, but they have kept a recruitment period of 1 year and then 18 months for post-intervention, and still 70% of the beneficiaries, they were there in the group. So I really feel that whether that particular population or the tribal population, which is very migratory, as far as I know, and they keep on moving. Now, in this particular area, whether they were stationed and whether the population is not migratory. And that is something which we need to look into, because most of the time, whatever interventions we used to do in Melghat, it never used to work so nicely because of the migratory population. Every time they will change. Today, you will go to their house and 2 days afterwards, you will not find them at all. So such thing usually happen in the tribal area. I think Chitra also will agree with me. She's working in the tribal area. But then how they could retain 70%, that is a very good actually figure of retaining so many children in the study and not getting lost to follow. That is something which needs to be appreciated. And then this intervention part for complementary feeding, that has really shown a very dramatic improvement. And definitely advice about the complementary feeding is very important in the tribal population. And somehow the study group has used certain techniques which has influenced the tribal population. Because this was a 480 children who were recruited for the study, taking into consideration all the sample size and all, 70% they have retained. That means that whatever strategy and whatever the education material which was given to the tribal, that probably they understood very nicely. And that is why the complementary feeding. Otherwise, in the tribal population, my experience is that whatever you tell them, they are very, very rigid and they are very strong in following their principles. As such, it's very difficult to convince them for our sort of a health education as such, which we have found. And so I think that that particular aspect needs to be borrowed, it needs to be copied in other areas also, so that the tribal population as such understands the educative part which has been done by the study group. And that is something which really needs to be appreciated, and we should follow the same thing. And otherwise, overall, I once again thank the organizers for giving me this particular opportunity to be with you all, and also Ashna for very nicely elaborating and bringing out the paper, which was really a tough paper as such, and with lot of statistical jagger which was there, but still she has brought out the things very nicely. And of course, all the younger postgraduates and the residents, they should understand the importance of actually the journal reading. And always when the students are reading the journal, my advice to them would be try to critically appraise the article, which is very, very important. Find out the strength, find out the limitations, which is very important, and also take something which can evolve or which we can understand. Like from this paper, we have understood that mere early initiation is not at all going to help the exclusive breastfeeding rates, which is something which is very, very strategically given in this paper, though they have not concluded it. In the conclusion, they have not included this particular aspect. But then we have to critically apprise and find out the solution for such problems. We should also raise the issues in the journal and try to find out in the research what more can be done. So with that, I would just once again thank the organizers, pranams to Mohanty sir, for being with me throughout, and for all of you for giving me this particular opportunity to be amongst you. Thank you so much.
Thank you, Sandhya ma'am. Thank you so much for your valuable comments. And we are having few people from actual Palghar district here with us today. So let us know actual things which are there. May I invite Dr. Jagdish Bhadvade sir, who is senior pediatrician and working in Dahanu, rural area of Palghar district, to give his comments in few words.
Yeah, good evening. At the outset, let me thank the moderator of Chitra Kulkarni for inviting me to give feedback about what the actual situation at the ground level is. Now, whereas this study which was presented actual intervention, what I am going to comment is what is the real situation in the hospital institutional level. Having practiced in this tribal bed for last 40 years in this Palghar district, Previously, it was Thane district. I can definitely vouch for the difference that has been seen in the scenario of under 5's malnutrition due to various interventions that are being undertaken by government agencies and various NGOs also. Because I have worked in the government setup under NRHM for a couple of years, and I'm also called upon for guidance in problematic cases. I can say that my observations are really first-hand observations. Gone are the days when we used to have epidemics of measles and diarrhea post these epidemics, news flashes in the media about deaths on massive scale due to malnutrition in tribal belts of Dahanu, Talasari, Vikramgarh, Jawhar, and Mokhada. Lots and lots of these tiny tots under 5s used to be seen with SAM, particularly during monsoon season when these areas were cut off from the healthcare facilities due to heavy rains or non-existent healthcare facilities. With various government agencies and some NGOs interventions, and with improved vaccination coverage of measles and rotaviral diarrhea, epidemics have now become a history. Introduction of PCV, that is pneumococcal conjugate vaccine in national vaccination schedule, has drastically reduced mortality due to pneumonia now. Additionally, government has actively started NRCs. We have an NRC at Dahanu SDH where I have worked for a couple of years. And there is one more at Jawhar SDH, that is sub-district hospital, both these are run by government. And one NRC at Mokhada is being run by an NGO. At both Dahanu and Jawhar, the experience is absolutely encouraging. Number of admissions due to SAM are reduced, but I admit that they are still there. MAM and stunting still continues to be prevalent. Death rates are grossly reduced and recovery rates are fantastic. About 10 to 15% and in some cases 20% weight gains are seen during the course of admissions for 14 days at NRCs. TB has drastically reduced now. On taking a feedback from Dahanu NRC, I am told that during the last 7-8 months post-COVID, when they resumed admissions at NRC, only 1 or 2 patients have been put on anti-TB drugs, that too presumptively. Attempts are always made to prove bacteriological diagnosis by CBNAT. Dahanu NRC caters to Dahanu, part of Talasari, Vikramgarh, and Boisar, and Palghar areas. During the course of treatment at NRC, apart from nutritional rehabilitation, the dietitian conducts training of the mothers about diet of their children. Various recipes are taught to them. Multivitamin and micronutrient supplementation is also done. And underlying an acute or chronic illness is taken care of during these admissions. And most importantly, the mothers are reimbursed ₹300 per day as the cost of the wages lost during the stay at NRC. This not only helps in rehabilitating these patients, but also ensures that after going home, the nutrition is taken care of, and therefore the relapse rates, which were previously very high, have dropped to less than 10% now. So the overall experience of supplementation of these patients is very positive. Now, to eradicate malnutrition, we have to pay more attention to not only the kid, but also of their mother, the pregnant women and the prospective mothers. So when they conceive, the outcomes will be good too. Prevalence of sickle cell anemia, I am surprised in the present study, there was no mention of sickle cell anemia, while sickle cell anemia is rampant in tribal population of Palghar district.
Yes.
So I'm surprised there is no mention of any sickle cell anemia. And in fact, the intervention this from 16% to I think it went to 0%. So sickle cell anemia is a real drag on the fight against malnutrition in these under 5s from our tribal area. These are my only few comments about what the intervention and how it has helped the tribal populations and under 5s in our tribal.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
We would also like to welcome Dr. Anjali Gokarna, President of Palghar Academy. Madam, welcome and can kindly share your thoughts.
Dr. Anjali? I could see her on the screen.
Not there at present.
Not present. No.
Okay.
Oh.
Mohite sir? Dr. Mohite sir?
Not there.
He's also there.
Okay. You carry on, Dr. Swati.
Yes.
Dr. Chitra.
Please unmute. Please unmute.
Yeah.
Dr. Chitra.
Now I invite. Yeah.
Dr. Chitra, if you permit me, I'll take 1 minute.
Sir, we are
That's
going
what-
to invite you
Invite
now
you
for the
only.
final comment. So
Wonderful
yours is the
time.
last word.
अच्छा हाँ टाइम
Okay.
खराब मत करो मेरे मैं ऐसे आ गया नो ना
Sir,
वो
you
मैडम
can
मुझे
start.
पता
So you are
था
our mentor and guide. Yeah.
I knew when madam is coming she is an authority. Before her nobody else can speak. She's not authorized to speak even. She is an authority not only Maharashtra but in the country. I still remember her presentation showing the Maharashtrian thali having a compliment dietary balanced diet. So that thing, those things has to be told to the Palghar or anywhere this study is being done. Visuals, more visuals. Dr. Badabade has rightly pointed out, and in the National Rehabilitation Center it has been done. But I would suggest what we have done here is, in the midday meal preparation in the schools, if the children will be involved in the process, they will go and carry this culture at least in the families.
Very
And
true.
from the families, others see they are also, they'll get motivated to do it. One of our very learned prime ministers once said, malnutrition is a national shame. And economic capital of the country, below it, we do not tolerate malnutrition in Palghar. We should not. We should eliminate it as fast as possible. This article is not published in any pediatric journal, but I located it in one of the PSM journals.
Yes.
So I thought it is very, very relevant in so far as methodology is concerned. And that's why we selected. Ma'am has already pointed out this thing. This I told to presenter, ये initiation of breastfeeding ये बहुत important है. मैडम पूछेंगे उसका फिगर कहीं है तो उसको डालो. मैं बोला था इसको और वो anyway इतनी जल्दी में वो हो गया है तो we have much appreciation for these two youngsters and they have done
Yes.
nicely. They have
Nice.
done it. They have done their best, no doubt about it. And thanks, special thanks to Ma'am Sandhya Ma'am for your kind gesture. Thank you.
Thank you.
Dr. Anjali Madam is
Yes, sir.
there, huh? Chitra Madam.
Yeah, Dr. Anjali, we invite you to give your special comments. You are from Palghar and you are president of Palghar Academy of Pediatrics. We want first-hand information about malnutrition in tribal areas.
Yeah, so where I practice, it's not exclusively tribal area. It's also a mixed population, cosmopolitan, but we do see some tribal patients. And yes, there is a high incidence of breastfeeding. Children do well till 6 months, but slowly, I don't know, the ASHA workers and some of the field workers are also encouraging tinned milk. And we are getting slowly, children who are on tinned milk, on very dilute milk. So the information about breastfeeding and correct techniques have not reached as much as the information about tinned food and packaged food. That is something new we are seeing and it's alarming.
Okay.
Comments and good
Anemia,
observation.
malnutrition. Anemia, malnutrition is still there. Weaning and complementary foods are still some things that are bothersome, and there is a lot of emphasis on giving very dilute feeds as well as giving milk as a substitute for food. So these practices are prevalent. That's all I'd like to say. And it's a wonderful journal journey.
Thank you, ma'am, for your extra comment.
I am tempted to say one.
Thank you, sir.
See,
Yeah.
I should not spoil the time like this. See, this breast milk substitute products entering into our Anganwadis and nursing homes. It is an organized crime being committed by the industry. They know that if a baby takes from bottle even once, it is so easy to suck. It will fill the mouth. And breastfeeding, actually, it requires a lot of efforts to suck the breast. They will not suck laterally, keep on crying. And the mother will think that child is still hungry, her milk is not adequate. They will go for continue breastfeeding, tin milk. So this is an organized thing going on. Many of us, we know, many we do not know. And with wholeheartedly, we should prevent this. No tin milk in nursing home. This nurse, they catch hold of the nurses. When they come, they tell us, sir, aapko se koi baat nahi hai. Please allow us to talk to your nurses. We should nothing do. They are the targets now. So the slip will go from a small slip from the nurse or the lady health visitor or whoever, even the ayah, and they get that milk. That is a failure on our part. Thank you.
Sir, the word which you use is organized. So there are the organized prescriptions already set with organized prescription written. Rather written, rather typed. And yes, it's a failure. And probably I must say each one I should read IMS Act. And recently the IAP has brought out the letter which is mentioning all the things about IMS Act. And probably everyone should read word by word of that. And though it is there, any act has loopholes. So maybe companies or maybe our fraternity also takes the advantage of that loopholes. But what Dr. Mohanty sir used, organized one. So really it is an organized crime and we are responsible for that. We should see how we can avoid that.
More introspection of our pediatrician is a must.
Yes.
Sir, it has come on the dais. That is very good. And all of us will try to follow it.
So one of my favorite word is introspection. So almost all the medical legal talks, I always say the word introspection. It carries good meaning for that. So it really requires introspection.
I agree with Neeman sir and Hemant sir both, because my PGs, both Dr. Ashna and Divya, they know that before discharge, we should ensure that every child should be on lactation, even though they are low birth weight or preterm. So it is our duty to focus, to continue, as well as Dr. Sandhya ma'am has rightly said that even after early initiation, we should
Okay. Now,
ensure that it continues till 6 months.
Yeah. Any questions in chat box, Dr. Neha? Dr. Jay?
Yeah, madam. I have one question.
Yeah. Yes.
First, unfortunately, the first fixation of the formula is not from the pediatrician by some other doctor, right? Hardly pediatrician attends any delivery or seizure college. He doesn't prescribe that. Is he pre-printed on where the child is delivered? And there is more of a seizure babies are more of a forward feed. Since the mother is not able to feed, उसको feed करने का position नहीं है, pain है, and that actually I don't think so. That encourages mother as well as maybe sister. Sister एक round सीख नहीं, breastfeeding अभी नहीं ले सकता, आप मोड़ नहीं सकते, formula feed दे दो. So once they start it, unfortunately that continues. It is very difficult later on to stop that, because the child comes to the pediatrician by 1.5 year or 2.5 years a month for the vaccination. At that time, already child is addicted to that formula feed and other things. So lactation failure already is setting. That becomes more difficult later.
So joint responsibility of both the branches, and we should counsel our colleagues. And therefore, the medical fraternity comes the word, not the specific branches.
Now you hear a word from Sandhya ma'am about breastfeeding after cesarean section. There is no problem. Anyway, you go ahead. with a
We know, sir, even ideally, even immediately in the OT itself, you can
Yes,
to the mother. We know that.
Breastfeeding can be started right in the operation theater itself. No need for the mother to sit or anything. The assistant can just put the baby to the mother's breast and the feeding can be done. Now, one thing which I would like to add here is that if at all you want no formula feed to be given to the baby, then there is a need for establishing comprehensive lactation management centers, CLMCs, which is very, 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 very important. That's why I am behind this particular establishing human milk bank wherever I am working, because once you say that do not give, if the mother is not in a position to, biological mother, if she's not there to give the feed to the baby, or there is some issue, then as a stopgap arrangement, definitely you can give a human milk instead of any formula feed. That is something which works wonderfully. And one more thing is that CLMC as such, that is not just for distributing the human milk, but it is for promotion, it is for teaching, it is for inducing lactation and so many things. And so that the mother is very well educated in the CLMC itself. And then this particular aspect, like if the mother is empowered and she is knowledgeable to that extent that I must feed my baby on breast milk only, no amount of your organized prescription will work. She will say that, no, I don't want anything. I want to give breast milk. So all this organized thing which you people are discussing, that will never ever happen if you are in a position to give an alternative to the breast milk to the baby in the form of a human milk from the donor mother. So that is why in Palghar now all you people should take active involvement and start some CLMCs over there, so that your organized way of this prescription and other things will stop. And one of the best thing as such, if at all you want to increase the breastfeeding rates right from early initiation to exclusive breastfeeding, CLMC is something which is very, very important. It's my experience after establishing around 12 milk banks all over the country and abroad. And I have got a great feeling that if there is a CLMC, no to the formula feed, and we can always follow the IMS Act to the maximum extent. Thank you so much.
Thank you, ma'am.
Madam, we agree, and with the properly said, everything perfectly said. But how to imbibe in the minds of the, probably I know you are working so hard for that, and probably you must be having some thing to design for that. But how to convince the otherwise to from means they are convinced, they know everything, but on the ground reality is not happening. So what to do to happen with the in association with Foxy or whatever means actually generates from there. So how to go about it? I think so. You must have some plans, or we can some make things interesting thing which can be imbibed on their minds.
Dr. Anjali wants to add something.
Yeah, what I'd like to say is that we need lots of lactation counselors, because this may not be the job of just pediatricians or other specialists. Lactation counseling is a super specialty by itself, and we need lots of lactation counselors so that we can refer patients, just like we have physiotherapists and we have occupational therapists. So perhaps lactation counseling should become a specialty or a subspecialty training for pediatricians or for family physicians, so that we can refer to them, because that is the way to go forward. That's the only way we can help mothers maximally.
We should train the obstetricians more, because the mothers, they take the obstetricians are their doctors. They don't know the pediatrician. After 3-4 days, they will understand who is the pediatrician, but they will listen to them. So we should rather motivate more and more the obstetricians and include this breastfeeding counseling in the antenatal council time, because they already make up their mind what to do. You have to motivate them in time, as Madam has rightly pointed out, Sandhya ma'am. And this is a task to the IAP Maharashtra to start a milk bank in Palghar district. It's not a big deal. If we want, we can do it. So many things we can do. Why not?
Yes, sir. Thank you so much. And over to Dr. Swati for the vote of thanks.
Thank you, ma'am. Thank you, sir. Thank you all the experts, Charul ma'am, Sandhya ma'am, Niman Monti sir, and Dr. Badbade sir, Gokarna madam. You have brought in great insights, made a difficult topic easy for us, and we have enjoyed this journey, and all our viewers also, hopefully. And we also thank Dr. Neha, editor Maha AP, for constant valuable support. Dr. Jay sir, and thank you very much, Chitra ma'am, for giving me this opportunity to share the dais with you. Thank you so much.
Thank you, our postgraduates, Dr. Divya and Dr. Ashna. Good try. We really appreciate.
Thank you, ma'am.
Thank you.
Thank you for your blessings to my students.
Thank you. Thank you, ma'am.